Melinda, hello, I'm
Hey.
Marcia.
Hi, how are you?
Thank you so much for doing this. I was so scared my computer wouldn't work. This technology stuff is making me a little crazy.
Don't say, it's usually fine, but I tell you, we had something, I was trying to project slides and run a meeting at the same time on Zoom a couple of days ago, and it was all fine until I had to let a couple people into the meeting. And then it just like my screen sharing totally screwed up. And so everybody was like, oh, I thought your internet worked. Like, it's not my fault. I'm trying to.
Information on this today, which I didn't get yesterday.
Okay, I have headphones on. Hopefully that will.
Oh, maybe try, are they plugged in? They're plugged in. Maybe I should try that. Maybe I'll go get mine.
That may help with echo.
I'll try. So I've got a big computer here that I don't get any feedback on, but I type on it during meetings. I can't really position this so I can type on my laptop. I don't know.
Yeah, it's difficult sometimes. I told my staff after that one meeting, I said, I am not running it and trying to, run the Zoom and run the meeting at the same time.
Kevin. But did everything go okay with Gloria yesterday?
Yeah. I mean, hopefully we can just flip to my screen. I'll just plan to share my screen, and hopefully I won't have any issues, since that's all I'll be needing to do is just advance my slides.
Oh, you know what? I've got, what's plugged into here? Oh, here. Okay, I don't know if this is going to work or not. I've never used these, but I'll see. Okay, speak to me, Melinda. Let me see if I can hear you.
Testing.
At all. These are not working. And I have wireless ones. I can try those. But maybe I'll just manage anyway. I don't know. You weren't hearing reverberation from me, right?
I'm not hearing it from you now, no.
It's bad on my end. I'll try my wireless ones, but I don't think that's going to make a difference. I'll be right back.
Okay.
So I don't know if it's connecting. See, it's connecting with my phone, which I don't want it to do. I'll turn this off. I have to turn off the Bluetooth. I don't think this didn't pick it up. Okay. Never mind.
Hello.
Hi, Gloria.
Hey,
Hi.
Hi, Leslie.
Hello.
Good to see you.
Good to see everybody. Happy New Year.
And to you. I'm not getting good reception here. I'm getting a lot of reverberation, sadly.
Okay, we should have. I don't know what he did here. Myself an alternate host. It's not working here. Should have made me the host. I'm an alternate host. Gloria Huggins. Oh, but you know what? I need to sign on as me, but I did.
Hi, Lorraine.
Belated hello. I didn't realize I didn't have my mic on.
So we have the retired guy with us.
It's not doing right. See.
Okay, did everybody sleep well last night? Oh my. Kathleen, it's good to see you, darling. It's been a while.
How are you doing, Chuck?
I'm doing great. I got my first COVID shot at the VA a week or so ago.
Was it
And
Moderna or Pfizer?
Pfizer, the frozen one. It was fine. I got a little. I've got a couple of rotator cuff problems in each shoulder, and it hit the joints a little bit. It felt painful for a few more days, but no, nothing they couldn't live with.
Well, that's good.
And the next follow-up is supposed to be February 2nd.
Well, you're very lucky. I had friends that both registered and got appointments yesterday somewhere, and one got a cancellation notice last night and the other one went out. And they had long lines of older people with canes and wheelchairs and walkers and everything else, and they wouldn't take any older people. It was all for healthcare workers, but they had not said that before they had people sign up.
Yeah.
Is this a result, Marcia, of the telling us to sign up and put our names on a list in Montgomery County?
These are, I don't know how these are two friends of mine, because they wrote me yesterday afternoon and said, oh, you've got to call right away. And we didn't, but they did, and they got appointments. I don't know where they got the link, where they got the information, but
I think it's from the Maryland.gov. Okay, the way it's set up is, I think the federal government give out, not only for Montgomery County, but, they have Adventist, Holy Cross, and those people can sign up.
But you know what? It would be really nice if there was some coordinated registry. And also, we can talk about this another time.
Well, the Montgomery County, you cannot even sign up until the 25th, with Giant or Walmart.
Right.
Yeah, so I'll wait till the 25th to sign up.
But they asked us to put our name on a list.
That's
Vivian.
a pre-register. So if you don't, they will call you if they have extra, they have more vaccine available.
But I
So
thought
you
that
put your name is only for pre-registration, and they will send you a message and
Yeah,
say,
but Vivian, they don't have the vaccine here, I don't think.
not yet, not until the 25th.
Thank you for bringing that up. This is a deal. We'll talk at length on the vaccine during our agenda. So if you wouldn't mind a question until we get there. Thank you so much. I appreciate it. We have quite a full agenda, and I see so many of our regular friends as well as new friends on the line. I see Dr. Raymond Kroll, the vice chair of our group, has joined us. So Raymond, if you could have opening statements, and then we proceed with the agenda. Dr. Kroll, thank you again for joining us. And I have to say that our vice chair from the Recreation Department, Director Robin Riley, is still in a council work session, but she will be able to join us a little bit later. So, Dr. Kroll, thank you.
Okay. Look forward to Robin joining us when she can. I apologize for being even just a minute or so late today. I have been literally pretty much in this chair all day doing one thing or another, and almost entirely related to, I'll give you two guesses, but you're only going to need one. It is about vaccine. I want to say Happy New Year to folks, first of all, and happy post-inauguration day. We've managed to see despite we might have been concerned about it, a successful transition to a new leadership at the federal level. And my team are all looking forward to seeing how things change, especially related to the pandemic and to the economic hardships that people have had to go through. We will talk about, I think, vaccine at some point during the course of the agenda. Happy to see you all again, and looking forward to this meeting and to what I have no doubt will be a productive and busy year for all of us. 2020, the calendar turned over to a new year, but we still have an incredibly long way to go in getting out of this pandemic, and a lot of work to do for our older adults community. So looking forward to having the conversation. Thanks.
Welcome. Thank you so very much. So I think a lot of people know each other on the line, and we have 30 some folks on the line. So I think it would take about half an hour of the times of a meeting if we were to go around. So I apologize. I'm just going to skip that. However, I want to welcome one special person, and that is Mr. Shane Rock, who has now joined as the new JCA, Jewish Council for the Aging Executive Director. So Shane, thank you for joining us. And I know David is still right there for a successful transition. And so I appreciate that. And again, welcome Shane, thank you for joining our team today. So at this point, Marsha, I know you have been able to have a fantastic speaker with the most perfect timing to talk to us about the vaccine and the testing. Outstanding director of the Office of Legislation, Policy and International Activities at the NIH right here in our backyard. So Marsha, do you want to take it from here?
We had worked really closely with Dr. Bernard, who many of you know, who is the deputy director at the National Institute on Aging. And so I had approached her a long time ago about joining us, and she said she can't because she's taken on a new role for Dr. Collins, but she highly recommended Melinda. And I've had many conversations with Melinda. I think she's looked a lot of our age-friendly materials and all, and I think we'll let her go from here.
Thank you so much, and welcome, Dr. Kelly.
Thank you so much. Okay, so I'm going to try to share my screen, and Marcia, if I have a problem and it's not advancing, please say the word because I might not notice. I think you have to allow me to share the screen, Marcia. It says host disabled participant screen sharing.
Gloria, can you let Melinda share the screen? Here.
Let me know when it's ready, Gloria.
Sean Brennan, you seem to be the host. I can't make myself a host. You
Sean
can.
is the host?
Sean is the host. Sean, would you be able to share the screen or make me host? Because it seems to be disabled that I cannot be.
Here we go. Okay.
Make me co-host. Oh, yes, and make me co-host also, Sean.
Definitely.
Thank you so much. Okay. It's
Okay. All right. Can you all see my slides?
Yes.
Yes,
Yep.
we can.
Okay.
Thank you,
Yay.
everybody. Awesome.
Terrific. Okay, again, let me know if they stop advancing as I'm speaking. So thank you so much to Marcia and the advisor group for a chance to speak to you today. As Odile mentioned, I'm the Legislative and Policy Director at the National Institute on Aging at the NIH. This is a topic I have to tell you in advance that I'm not the expert on COVID-19. My office deals in very, very high level policy issues, typically related for the most part to Alzheimer's disease and general aging research. But I'm going to attempt today to tell you what I know in terms of some of the overarching projects and programs at the NIH that you may or may not have heard of. I know this has been in the news so much that much of what I tell you may not be a surprise to you, but hopefully I can give you a few new nuggets of information. Talk to you about the programs at the NIH and also some of the more recent science advances on the COVID front, and then where we're going to be going in the future. And I will talk to some degree about social isolation and loneliness, because I know that's a topic of interest to this group. I am getting a little bit of noise, so if folks could mute their lines, just so that I can hear. Thank you so much. Okay, I'm going to start with some good news, because I think there's been so much bad news with COVID. It's been just a long and terrible year for the country and the world. So the first thing I want to mention is just that we, and by we, I mean the NIH, we were really ready for this. Nobody really wants a pandemic to arrive on our shores, but there had been decades of work at the NIH previously, particularly at the Vaccine Research Center, which is run by Dr. Fauci's institute, on what we call test case or prototype coronaviruses. So trying to study the way coronaviruses operate in general and thinking about how would you develop a vaccine or could develop a vaccine that you could then tailor to specific coronaviruses that would address that particular virus, but also be tend not to have side effects in humans and also to be scalable. Because one of the issues, as you all know, with the coronavirus, COVID-19 has been the production of the vaccine. You need to be able to make large quantities so you can be ready to vaccinate hundreds of millions of people around the US. So that preparation has really made a real difference. And the best analogy I could come up with for those of you who've seen the movie is this quote from The Martian. So in the face of overwhelming odds, actually my little screen thing is blocking the quote. In the face of overwhelming odds, I'm left with only one option. I'm going to have to science the heck out of this. That's not really what he says in the movie, but I tried to keep this PG. For those of you who haven't seen the movie, Matt Damon plays a botanist who is stuck on Mars, and he's got to use his scientific skills, everything he's learned up to date when he landed on Mars, to try to save himself. So if he hadn't had that foundation of knowledge, an understanding of plants and so forth, he wouldn't have been able to survive. And I think that's really what we faced with the coronavirus. It would have taken us much, much longer to have the vaccine ready. When you look at the time we've had, it's been only 10, 11 months in development, and we've already got it on the street. That would not have occurred if we hadn't had all this preparation beforehand. We've had the funding. So Congress has been quite generous in terms of NIH funding for the coronavirus research. We've received almost $5 billion to date in supplemental appropriations for these activities. And that's gone to all the projects that I'm going to be talking with you about today. Just to give you some context for this amount of money and what this means for the NIH. So if you look at the NIH institutes, and I'm at the NIA, we're currently the third largest institute at the NIH, which is actually an amazing feat. We haven't advertised it that much recently, but when I started at the NIH 6 years ago, we were the 10th largest institute. So we've got a lot of money, and it's terrific. But if you look at the amount that coronavirus research has gotten, it actually would place that research as a chunk of money in the third position of 27 institutes. So it would come after NCI, the Cancer Institute, the Allergies and Infectious Disease Institute, which is the one Dr. Fauci runs, and this would be third. So it is a substantial amount of money. And NIH has put that money into use right away, and it's been tremendously helpful. We're of course vaccinating, and I won't even attempt to get into all the challenges with the vaccines and at the different state level implementation and the problems people have had with appointments being canceled and so forth. But just to think about the unprecedented speed with which this vaccine has been put on the street is really amazing, and it really speaks to the importance and value of scientific research. And then of course, we know how to reduce the spread in the meantime. All these factors that have been pushed out through the news and social media, they're going to be critical in the future as well, because even once people are vaccinated, we won't fully know for some time, number one, how long the vaccines will offer protection, but the degree to which they'll offer protection from asymptomatic disease transfer. So we will need to continue with some of these social isolation, mask wearing, and so forth, some of these behavioral strategies, I think for some time to come. I wouldn't want to speculate for how long, but I don't think we can assume that, as people get vaccinated, we can drop all of these right away. And I wanted to point out, so I've got a link at the bottom of the page. So after I review all the content today, if you're interested in a slightly deeper dive into some of these details, I would urge you to take a look at this video cast. It's a presentation that Dr. Fauci gave actually just a couple of weeks ago on COVID-19. It's as part of a demystifying medicine series that the NIH runs, looking at a number of medical issues. And it was a really great talk, and it's in more detail than what I'm going to give you today. So if you're interested, I would definitely take a look at that presentation. So in terms of the various NIH programs that have contributed to the COVID-19 response, so this slide just gives you a snapshot of the major elements of the NIH's response. And I took this from the strategic plan for COVID-19. And if you want to take a look at that, it's provided, the link is provided at the bottom of the screen. None of this is going to be a surprise to you. The NIH focuses on improving knowledge about the disease, improving detection, advancing treatments, accelerating prevention research, but a major part of the disease strategy and strategic plan has been trying to address poor COVID-19 outcomes in health disparity and vulnerable populations. And I'll show you some examples of the specific projects that are addressing this in just a minute or two. And then of course, you've seen Dr. Fauci on the news dozens and dozens of times over the last year. You know that the NIH is playing a role in the federal decision-making, working with the executive branch, the president, and the Department of Health and Human Services. So we've been very involved in that, and the institutes have been as well. So it's not just Dr. Fauci's institute. I should point out that all of the institutes have been playing their own part depending on the type of research that they conduct. And some institutes have taken a lead in some areas more than others, but they've all been playing a role. Okay, so the three projects that I want to talk with you about today, and if you don't take anything else away from this presentation, if you can just remember the main three projects and the areas of focus, I think those would be key take-home points. The first is accelerating COVID-19 therapeutic interventions and vaccines, or the ACTIVE program, the Rapid Acceleration of Diagnostics, or the RADx program, and the NIH Community Engagement Alliance, or SEAL. And this is focused on the health disparities issues. And I'll give you some examples of each of these in just a second. So the ACTIVE program, this is focused on vaccines and therapeutics. And this is where you're getting things like the Moderna vaccine coming out of. And this is led by a public-private partnership, which I don't know how widely known that is in the news and so forth. This is run by the Foundation for the NIH, which is an organization that's not part of the government, but has the ability to bring together monies and contributions from a lot of different sources. So it can bring together federal dollars as well as pharmaceutical contributions and get some of these massive projects going. And this particular partnership, ACTIVE, has had NIH involvement, BARDA, which is the biomedical preparedness part of the federal government, CDC, Department of Defense, FDA, VA, Operation Warp Speed, which I'm sure you've heard a lot about on the news, and the European Medicines Agency, which is essentially the FDA of Europe, as well as research universities, other funders, and of course, pharma. And I know that you all know, because you've seen on the news, but I'd be remiss if I didn't have a slide on this, which vaccines are currently being distributed. There's the Moderna vaccine, which NIAID, the Allergy and Infectious Disease Institute, was very involved in working on. And then not part of the ACTIVE protocol, but the Pfizer vaccine is also on the street now, fortunately. And they both received emergency use authorization in November. And some of you may be aware that the bar that you have to meet for emergency use authorization is not quite the same as you would normally have to meet for full FDA approval. Emergency use authorization really addresses when you have a medical situation where you have no other therapy and you're really looking at do the benefits of whatever the investigational drug are, whether they outweigh the risks. And in this case, both of these vaccines met that bar. And of course, there are several other vaccines that are in the queue. And in fact, Dr. Fauci was on the news this morning, and I believe he said the Johnson & Johnson vaccine is quite close now, and that the researchers are going to be analyzing the data in the next few weeks. So hopefully that will also receive the EUA approval. I did also read that even though the bar for the EUA is different than the sort of standard approval, the FDA did try to essentially use as much of that higher level bar as they could when they analyzed the data coming out of these two companies, of whether they were going to give the EUA approval. So they tried to meet the bar as well as they could in this situation, because of course the drug is going to be used by so many people. So I think it's pretty promising having two on the street, even with the problems with people getting vaccinated. I do think it will happen. And at the end, when you guys talk about it, I do have a tip on how adults, I think it's over 65 can get a vaccine in Montgomery County, because my father-in-law just got one yesterday. So I can throw that in when we talk about the vaccine availability. Okay, so shifting now, so that was the vaccines. The other part of ACTIVE are the treatment protocols. And there are 5 key kind of umbrella protocols that are underway right now. And I'm not showing, basically when you see these slides that I'm showing, there are so many dozens of activities. It's like a hive of activity happening under each of these. So this is just a huge oversimplification in terms of what's happening at the NIH. So I'm just giving you the bird's eye view. So the first ACTIVE protocol is really looking at the overactive immune responses. You may have heard about essentially people having what is a cytokine storm, kind of a dumping of immune chemicals, which can lead to serious complications as well as death in hospitalized patients. And so trying to intervene in these overactive immune responses is one strategy. And so there are a number of studies looking into that. The second and third overarching program in terms of treatment development are initially looking at antibody trials, both in seriously ill people in the hospital, as well as people who are not as significantly ill, who are out of hospital, and pulling antibodies from things like like serum from recovered patients. But these 2 studies will move on, I believe, to test things other than antibodies, but right now that's their focus. You're probably also aware that one of the serious side effects of COVID is a coagulopathy, or major clotting problems throughout the body. And this again can lead to significant disease and death. And blood thinners are in the queue being looked at. And this is not just one blood thinner, but looking at multiple strategies. And then similarly, we've got an umbrella kind of for all comers. So lots of other drugs having an opportunity to be tested as well. And I wanted to point out when I had this slide up that for those of you who are familiar with the NIH, you know that one of the sort of core facets of what we how we hold up our research is peer review. So essentially people coming in, investigators coming in with grant proposals or contract proposals and putting those forward to other scientists to say, is this a quality research plan? And that is also being done with the protocols and the studies of COVID. Just because we're trying to move things rapidly doesn't mean we're skipping peer review. So that's still an important facet of what we're doing, because just because we have a lot of money and it's a crisis doesn't mean that funding bad science is going to get us the answer faster. So I just wanted to make sure I mentioned that. Okay, so shifting to part B, so that was active. So that was therapies and vaccines. Active is diagnostics, so RADx. RADx is diagnostics. There are multiple components to this as well. And again, imagine a hive of activity under each of these. So RADx Tech is looking at technology for at-home or point-of-care testing. And they actually implemented really quickly, right out of the box back in the spring, a Shark Tank kind of approach where they had lots and lots of people throw in ideas, and then they filtered them out through several stages and then connected those researchers, the ones who essentially won and got the funding, with businesses who could help them to implement those tests in real world practice. The second component is RADx Underserved Populations, or RADx UP. This is focused on enhanced testing in underserved and vulnerable populations. And I'm going to show you one more piece of information on that in just a second. Obviously, a very, very important facet of what we're doing, not just in the testing scenario, but also in not just in diagnostics, but also in treatments and prevention strategies. And then RADx Radical is looking at different kinds of testing approaches, not just the saliva or the nasal swab, looking at things like community wastewater analysis. So really opening the door to lots of different approaches that investigators might be able to come up with to do a better job of testing in different situations. And the last one is, it sounds very dull, RADx Advancing Technology Platforms, but what this is trying to help the diagnostics that are happening in labs and places around the country to be able to increase their efficiency, their capacity, things like that. So you, because the speed with which they can get that testing done does make a difference in terms of the spread of disease and so forth. So it sounds a little dull, but it is an important piece of the overall RADx approach. And I said I was going to say, we'll just make one more point about the RADx underserved population. So just to give you a sense for how widespread is the money going in these kinds of projects. So I think this is a particularly good one to show a map for. So these are states that got at least one RADx UP award, and you can see that that they are reaching some populations where you can imagine that there would be lots of underserved, diverse individuals in those states. We're not touching every state yet. But one of the things that the NIH has done throughout a lot of the COVID kind of clinical hands-on research where human participants are involved, is they're working with established researchers and the networks that already exist to reach the populations that we need to reach. Because that is, if you already have the infrastructure set up, it allows you to get things going much, much more rapidly. And so I think the first step that they wanted to take, doesn't mean that that's the only step they're going to take, but the first step is really to maximize the utility of those networks, getting out, finding out what, in this case, what the testing pattern is for COVID-19, and then trying to improve access starting from there and the reach and the uptake. And this will of course be, I think, moving forward for some time to come. And I would imagine that, you know, down the road, there will be more awards for more states, but I just wanted to give you a sense for the breadth of the funding, at least for this particular part of the diagnostics program. Okay, moving on to the third program, the Community Engagement Alliance. This is also focused, very importantly, on COVID-19 disparities. But this part is really about education and addressing misinformation and mistrust. So I'm sure that most of you have seen, if you've been watching the news in the last year, that there have been a number of surveys that have gone out to try to determine, and the surveys were done before the vaccines got the EUA approval, but really asking people, when the vaccine is available, are you going to get it? And this survey was done back in May. And if you take a look at some of these, the age groups and the different health disparity groups, you can see that there's a wide variation in whether people were going to be willing to accept the vaccine or not. And some levels, I think, particularly in the Black community, very concerning. And it's very understandable when you think about how disenfranchised many health disparity communities are. in terms of having, not only are they at greater risk in some cases because of the jobs, living situations, and so forth, they have a history of being disenfranchised in terms of access to medical care and mistreatment. So it's very understandable, but what we don't want to have happen is for the clinical trials and the treatments, especially the clinical trials, you can't be testing these in middle-aged white men and expect they're going to work in men and women of different races, different ages, and so forth. So we've got to get a really diverse group in for the COVID-19 prevention and treatment trials. I believe that's been the case so far, at least for the COVID, the two drugs that are on the street, the two vaccines. So I think Moderna and Pfizer, I believe, did a good job of having a diverse population in those trials, but that's got to be the case going forward. So all of these studies that we're doing, they've got to enroll a diverse population, but you can't do that. You know, you can ask, but if people aren't willing to participate, I mean, they're research partners. And if folks feel like there is a sense of mistrust, they're not getting clear information, that's going to be an ongoing problem. So that's what this SEAL project is really looking to focus on is education. And this is a different map, just again to show you the spread of some of the funding. And this is just the initial chunk of funding that went out across 11 states. In the same way that the other projects I mentioned, some of the clinical trials have utilized networks that already existed. In this case, what NIH is doing is working with national organizations that have local affiliates that already have a reach in the communities that they need to educate. And they want to get the word out to bring them into clinical trials and so forth. And as well as NIH funded researchers in those communities, and then other federally funded programs where you might have reach. And hopefully, you know, this combined with some of the other activities, we can ensure going forward that we've got basically like sort of the soup to nuts coverage in terms of educating communities of all races and ethnicities about the disease, understanding what's happening in the disease, the risk, mitigation strategies, going forward to involvement in clinical trials, and then as therapies come out, making sure that everybody is having access to those therapies. All right, I'm going to shift once more to talk a little bit about research. And so my office, one of the things that we do is we curate all the scientific advances that come out of the NIA. And as we've gotten bigger, there is a massive amount of information. And just the sheer number of COVID advances has been mounting in the recent months. I think it took a while for researchers to, you know, collect the initial data from some of the early studies, put that together, get it published and get it out there, but it's accumulating all the time. So I'm just going to show you just a very small number of advances, but if you're interested, you can certainly contact me and I can provide you with some more links if you want to learn more. So, you know, one of the questions for older adults in terms of COVID-19 is why is the disease so bad in older people? And I think that is going to take a lot more study, at least from what I can discern from the literature. This is just a single paper that came out looking at the immune system and some of the changes that might be contributing. And I will tell you, this was a super technical paper. I tried to kind of summarize some of the cellular changes that could be playing a role. Everything from the immune system being in sort of some parts of the immune system being declining in older age, but also at the same time overactive is one contributor, particularly I think to that cytokine storm when people have kind of just a blast of immune molecules that can lead to death. Other kinds of changes to cell signaling pathways. Some of them are result of contributions of metabolic disease because you have a lot of older people who are also having diabetes and obesity and other risk factors. You've got people who have whose immune systems are reflecting their advanced biological age as opposed to their chronological age. And biological age is where you have changes to the way genes are expressed, not the changes to the genes themselves, but the way they're expressed in cells that results from an accumulation of environmental exposures, poor behavioral choices, in some cases genetics, which is not anything you can do anything about, but these all play a role in the way your immune system is going to work when you're 65, 75, 85. And of course, it's different in different people, but this is going to take, I think, as I said, quite some time to sort out. But researchers are beginning to investigate this and certainly something that we're funding at the NIA. In terms of risk factors, I don't think this is a particular surprise to you, but this is continued, researchers that we're funding are continuing to study this. For this particular study, you can see that current smoking, physical activity, obesity, overweight, diabetes were all sending people into the higher risk category. Again, not a surprise, but I did want to, hang on, let me get a drink. One point I wanted to make on this that I had been thinking about, and I haven't necessarily seen any articles on this, and I'd be curious to hear what your group thinks. So I spent some time a number of years ago working at the Heart, Lung, and Blood Institute, doing actually community health outreach. And at the time, we worked with folks who were experts in social marketing, and we really struggled working with them on some of our outreach programs on how do you really communicate the need to shift into healthier behavioral choices in terms of preventing overweight and obesity, increasing physical activity, improving diet. And it's not that you want to scare people with messaging, but there was always a sort of balance of like, if you tell people they're going to get diabetes or heart disease, is that going to convince them to make changes? Or do you try to take a positive tack? And I don't know. I mean, I haven't followed the literature as closely in the last few years, but I don't know if there's ever been a real answer to that. I do know that in the recent years, when I've been working more on Alzheimer's disease and brain health, I think that is a little bit scarier to people as connections are now being made in sort of connecting heart health to brain health. I think that may be a message that may resonate a little bit more with people, because people don't want to have a stroke and they don't want to end up with cognitive decline and Alzheimer's disease. But I am wondering if the risk, the great risk that obese individuals have in terms of COVID-19 might be a tipping point for public health education in this area, because this is something that came completely out of the blue. And by the time it was here, it's not like people who were obese really had a chance to try to lose the weight and put themselves in a lower risk category. So I don't know, but again, if there's a minute at the end, I would be kind of curious to see what you all think about that. So I also wanted to mention neurological disorders resulting from COVID-19 infection. You hear a lot about the lung problems and the clotting problems and so forth, but the neurological disorders are really, I think, quite concerning. So this was one study of over 4,000 people hospitalized in New York City. Of this group, 13% developed a neurological disorder, and these ranged from things like seizures to strokes. And then this is also from the same study. You can see some of the other risk factors for people developing these neurological disorders, but having a neurological disorder when you had COVID-19 did not predict great things. Decreased likelihood of discharge home, as well as increased risk of in-hospital death. So I think this is concerning. Here's another perspective on cognitive disorders. So for those of you who aren't familiar with delirium is a really strange condition that can affect, it can affect people of any age, but particularly older people who are coming to the hospital for sometimes things like major surgery, like they could have a hip fracture and they need a hip replacement surgery, or they have like a complex urinary tract infection, and they're staying in the hospital, maybe in the ICU for a while, and they will develop kind of some very strange kind of disconnected behaviors. So they're confused, they can actually range from very kind of agitated and hyperactive to very hypoactive, but they're sort of disconnected with reality. And this would be bad enough if it just happened in the hospital while you were being treated. But the problem is a lot of people, especially older people who have this, they go home and the symptoms continue. And if you have any kind of cognitive decline when you get these, the delirium symptoms, sometimes you never get back to the mental state that you were in before. And so it's a really problematic condition. NIA is doing a lot of research to study it. But I think this research shown in this slide is particularly concerning because this study showed that of the older adult folks presenting with COVID-19 in the emergency department, 28% had delirium. And of the people who had delirium, 37% didn't have your typical COVID-19 symptoms. So they weren't, the people who were, in terrible shape. And again, like the previous neuro study, these folks also had a higher risk of an intensive care unit stay, as well as death. And so I think there's going to be a lot that will need to be invested going forward, not just on the other organ systems that are affected by COVID, but also the brain function and whether or not there are long-lasting effects of COVID. And I'll talk about that at the very end of my presentation. Okay, I'm gonna move on to social isolation because I know you guys are interested in that. So I don't think this is going to be a surprise to you that under normal conditions, so non-pandemic conditions, social isolation and loneliness increase risk for a wide range of unfortunate health conditions, everything from cardiovascular problems, obesity, immune problems, and then multiple mental health conditions. And social isolation and loneliness are dealt with sometimes together, but also separately in the research literature, because you can be socially isolated but not feeling lonely, and vice versa. And so they have to be looked at as, I think, separate impacts, separate but related. And then, of course, people who are in vulnerable populations like those listed below are also at greater risk. And again, with this slide, I added just a couple of little extras for you. So the first link, if you want to read a little bit more about our research activities in this area, not having to do with COVID, but just generally, this is a blog post that came from the lead of our social and behavioral research division. And so I don't think that's very old, that blog post. So you might take a look at that. And then the second link is to an interagency webinar. So we've worked with CDC and ACL on some webinars of various topics of interest to older people and research topics. And this one was focused on social isolation and loneliness. So if you want to hear directly from the researchers about what's going on in some of the labs that are exploring these topics, you could take a look at that webinar too. Okay, so what do we know from the research so far? Some of what has been shown has actually been, I think, sort of unexpected. I'm pretty sure that if most people had to guess at the outset of the pandemic, they would have said that older individuals might have fared worse in the pandemic overall than younger individuals. But this study, and I've seen others too, that suggested that older adults have actually, on average, been a little bit more resilient and have shown less loneliness. So here you can see, and again, this was, a lot of the data are coming from early in the pandemic because we don't have data, from 2 months ago. So in this study, looking from February to April, it was actually the older adults who started out lower on the loneliness scale and stayed about the same over the course of this data collection period. Middle-aged adults were next, and then young adults were actually the highest. So they had the worst loneliness scores. And again, I've seen this in other studies as well. So it's, I don't think this is just a chance finding. But this study noted, and then I'm going to show you another study in a second, that have found that even though if you look on average, you might see these trends, it doesn't mean that there aren't select individuals in the studies in the older adult population that are experiencing loneliness due to COVID very, very keenly. And I guess I'll point out here that I think, a take-home message, and again, this is not, based on a huge quantity of evidence because we don't have it yet, but if you're working with older adults in the community, I would say don't make any assumptions about everybody doing great. I think there will be people that will need interventions and strategies, contact strategies to be tailored to them. And I know just in my own life, just differences in my father-in-law's been doing he's 86, he's been doing quite well. He and his dog are together living independently. And we've been visiting him socially distant, bringing him food, making sure he's getting his groceries and things. He's doing quite fine. Whereas I have a friend whose mom is actually a little bit younger, and she has had such anxiety and that my friend is actually worried about her cognitive status and has had her undergo some neuropsychiatric tests because she can't tell if she's just so anxious about COVID and upset about that versus having some sort of early cognitive decline. So it's, I think it's all got to be very tailored to the person, but I think on average, we're seeing some resilience among the older adult community. This is another study that also sort of pulled out some different categories of older people. And this was done in San Francisco right when the shelter-in-place orders were put in place at the beginning of the COVID pandemic, and then checked up at multiple time points to see how older adults were doing. And they actually put the older adults in their study in sort of 3 categories based on the findings, the qualitative interview findings. And I'm going to give you 3 examples, and you can see the differences in some of these interviewees. So this person was in the group whose loneliness scores increased over time. So before the virus, this person said, I was socializing, seeing people a lot, but I feel a lot more lonely and isolated. And then following up, this person is really frustrated with technology and feeling totally out of date. Here is another individual who fell into the high loneliness score group that did not change over time. So it was bad before and bad after. I'm so used to not doing anything. This has been terrible. First follow-up, this has been the hardest thing I've ever had to do. It's made my mental and physical health worse. Second follow-up, and the longer the coronavirus situation is, the more on edge people are. So that person is not in great shape mental health-wise. But then you have other older adults, and here's one in the sort of mid to low score group that did not change over time. And so the person started out, I'm pretty good with technology, I'm okay with Twitter, Instagram, FaceTime, and then by the follow-up, they're going out to the Arboretum. So if you look at the study overall, what they found on average was, again, you see resilience. So 46% expressed loneliness at 4 to 6 weeks versus 27 later on at 13 to 15 weeks. But there were these subgroups of people for whom it was really, really challenging. So again, the take-home message from this, at least, you know, the way the research is looking right now, is I would say, don't assume anything about particular groups of adults, sort of, you know, writ large. Really try to think about the individual people that you're working with and what their needs are. All right, I'm just sticking this in here because basically too much media exposure is bad for anybody during the pandemic. This is not just older adults. Increased mental distress is associated with time spent on social media and the number of media sources you're using. So this is probably not a surprise to anybody. If you cut down on your media use, particularly in a situation like the one we're in now, you're probably going to be better off in terms of your mental health. And then I've got a couple slides that sort of show some cumulative information that I pulled from a number of different, not research papers, but reviews that were sort of looking at the social isolation and loneliness literature and kind of thinking prospectively about what we really need to be investigating in terms of the scientific community going forward. And so some of the possible strategies, and again, this is not, you know, based on a large body of evidence because this is also new, but some of the strategies that seemed significant enough to be explored further among the researchers with delivering therapies remotely, which I'm sure is already being done all over the place, sort of cognitive behavioral therapies and things, therapeutic approaches that would have normally been done in person, social connectedness, regular sleep and meal times. I put my picture of my dog on there because she's very good at making sure that we keep to a regular schedule, healthy diet, cognitive stimulation, physical activity. All these things, they're not surprising, and I don't mean to sound trite about them, but you know, overall, I think to the extent that these can be integrated into everybody's lives, you know, generally people will feel better. I mean, certainly people still have serious mental health issues that will require some additional therapy, but I think, you know, staying with sort of the basic themes that you would normally think would help people who are isolated and lonely can help with, you know, COVID-19 isolation as well. And then some specific research questions. So just again, the kinds of things that will be looked at down the road when you transfer things like cognitive behavioral therapy from the office setting or the group setting to a remote setting, you know, via phone or computer, you have to test to see if it still works. So you can't just assume if you change the vehicle of delivery that the intervention is still going to be as effective. So if your therapy, does it still work if none of it's in person? Does it matter if it's the phone versus the computer? And then you've got interventions for isolated older adults who have cognitive impairment, who maybe are in the early stages of Alzheimer's disease. And there are many people, I'm sure, as you know, who are living alone, who do have Alzheimer's or other forms of pre-existing mental illness. And so you can't necessarily, you know, you have to think about this when you're trying to adapt strategies, particularly in research testing scenarios. And then we have older adults in long-term care settings. So they're not as isolated, but they're isolated from their families. And so the strategies there, of course, need to be tested as well. All right, I didn't want to leave you without mentioning sort of where you can find more resources for individuals in the community. Because at NIH, we're not all about conducting the research, we also want to get it out on the street and have it be used. And as it turned out, when I talked to our communications office about this presentation, they told me that, as luck would have it, they are actually developing a landing page called Stronger Connected that's going to house all of our social isolation and loneliness resources. And this will go live on February 22nd. And so after that point, when you go there, you will see the old information, but you will also see a new easy to read booklet, as well as an outreach toolkit that I think would be probably very useful for some of you in terms of your community engagement and activities. And so please feel free, again, you're going to get the slides afterwards, so feel free to check out the website once it's up. And then also, If you want to sign up for our Facebook Live Q&A event on March 4th, we will actually have an expert, because I'm not the expert in social isolation and loneliness. One of our behavioral science experts will be on board for that Facebook event to answer questions. So please feel free to join that and distribute that information to anybody else that you think would be interested. And then looking ahead in 2021, I think there are some positives out there. Besides the evolving vaccine rollout, there has been a universal coronavirus vaccine in development. It did get a little bit waylaid, is my understanding from some of the reading I've done on Dr. Fauci's institute. It got waylaid by needing to address COVID, but I believe it will continue in 2021. Participants are needed for clinical studies. This is another key message to get out to the community. This includes people who have had COVID, and people who have not had COVID. And either one of these links will take you to clinical trials where people can sign up if they're interested. I do believe that the expansion of remote technology during COVID is likely to have a lot of benefits, particularly for older people moving forward in terms of interacting with family, particularly for older adults who live far away from their families. Things like medical visits. I think the telemedicine has been particularly helpful. I know it's been helpful for me, and I suspect for lots of older adults who have trouble with mobility. And then the last thing I wanted to say, I had kind of referenced it at the beginning of the talk, is thinking about the long-term effects of the virus. So I mentioned the neurological effects, and that is the significant concern. But there are other effects in people who have had COVID, that respiratory effects, fatigue, that it's clearly not just in the people's minds. This is really a significant health issue. And the NIH is very concerned about it. And they had actually an initial sort of big workshop in early December. And I know that there is a lot of planning. I can't report anything out because I believe that the planning is sort of happening this month, coalescing the plans from different institutes in terms of what they can offer. Again, I think what they'll do for looking at the long-term effects in survivors is they're going to try to use the studies that have already been funded, like the longitudinal studies where you're looking at the same group of people over time. If you can tap into some of those studies and see if folks involved will volunteer to report on whether they've had COVID, to maybe give additional blood samples and so forth, and report on their symptoms, you can use those to kind of accelerate studies of this type as well. But there will be much more coming out this year in terms of the follow-up. And if Marcia would like, I can certainly send you guys some follow-up information down the road if that would be helpful. And then if anybody is interested in actually watching this workshop, it's a very scientific workshop, but I'm happy to send you guys the links because it was public. So I'll share those if you want to email me after. This is the HHS Combat COVID website. I have no idea if this is going to change now that we have a new administration, but I would imagine that the elements of it are not going to change. We still want people to join trials, donate plasma, and then collect information. And so with that, I will stop and stop sharing my screen, and then I can try to answer questions. But as I said before, since I'm not an expert, I'm very hesitant to give information if I'm not confident in it. So please feel free to email me because we can certainly collect whatever responses you need if you have detailed questions. So thanks so much.
Thank you so much, Dr. Kelly. Thank you for sharing your expertise and all this fantastic information with the research and the science, and also for sharing your email address. You're going to hear from us right now, as a matter of fact. So I do have so far a few questions. And
okay.
One is, does a universal coronavirus vaccine mean that it fights all kinds of coronaviruses?
Okay, so I believe that the universal coronavirus vaccine would be, so you've heard probably for years and years about researchers trying to develop a universal flu vaccine. You know, because each year what you hear when you go get the flu vaccine is, you know, oh, I got the vaccine, but it's only, you know, 40% effective. It's because the researchers have to guess, the pharmaceutical companies have to guess ahead of time what strain is likely to be on the scene. And so if we could have a universal flu vaccine, you wouldn't have to be guessing all the time, and presumably it would be more effective. I think that's the same goal with the coronavirus vaccine, because honestly, we don't know. I mean, you've probably heard about these, the mutations in COVID-19, and you know, some of them are more or less concerning depending on what part of the virus particle gets mutated. It's interesting because so as I was reading about this, because I'm not an immunologist, apparently if the spike part gets mutated, that can actually make a particular strain of coronavirus less infective because it can't be transmitted as effectively. So I thought that was interesting, but I guess my understanding is mRNA, messenger RNA viruses do mutate a lot. And, I don't know going forward whether we're going to end up needing, COVID vaccines every year for COVID-19, or whether we'll need additional strain, if mutations happen and they become very prevalent in whatever % of the population has not been vaccinated. I just don't know how it's going to play out, but I think the goal of the universal vaccine would be that you wouldn't be trying to guess and play catch up with the various mutations and so forth.
Thank you so much. I encourage everyone to put your questions in the chat. I'm just reading them in order. I see a lot of kudos for your presentation, Dr. Kelly, so be assured that we appreciate you sharing your time and your expertise with us. Another question has to do with if this kind of universal vaccine will effectively work for coronaviruses. What about the common cold? That's a $1 million question right there.
Yeah, that's a good question. I can look that up, and actually I'm going to try to get a copy of the chat so I can get back to people individually. I would suspect that a universal coronavirus vaccine would address the common cold too, but I don't know that for sure. One thing I did see in reading about just dealing with coronaviruses in general is the vaccines that are available now are only about 95% effective, which is amazing. But we're probably always going to have some element of COVID-19 in the population. And I think the goal would potentially be that, if as we move forward, if we could keep the levels down, eventually it might evolve into something, COVID-19 itself might evolve into something that's no more bothersome than the common cold. But I will double check and get back to Stuart about, well, actually, I can answer all the questions for everybody if you guys want to distribute them, and to see if the universal coronavirus vaccine would cover the common cold as well. That's a great question.
Yeah, I agree. Thank you so much. All right, we have a couple of comments about, do you have any secrets for us to get more vaccines in Montgomery County?
All right, so I'll tell you what. So I'll tell you what happened. So I personally signed up. I did the crazy sign up with I guess it was marylandvax.gov or whatever, the one that was coming out of Prince George's County. So we got all signed up on that. And then my understanding is that if you're in Montgomery County, which I am, they're going to cut off the Montgomery County people. That's what I have heard after like February 9th or something. So I'll probably not get a vaccine, but I got a tip from a friend that older adults, and I'm not sure where the age cutoff is, if you are in the Hopkins medical system, if you have a Hopkins portal, which a lot of people do through various doctors, you can go into the portal and register for a vaccine, and they will give you essentially a callback and give you a time or give you the option for signing up for a time. So we did this about, I don't know, 3 or 4 days ago for my father-in-law, who's 86. He got vaccinated yesterday. And the friend who told me her mom also got vaccinated yesterday. And so I think the portal knows how old you are. And so it's going to know, because I went on the portal just to see if I could get on a waiting list because I'm 53. And there was nothing on there for me. So there wasn't like, oh, you can get in line now and get your vaccine in 3 months. So I think it knows your age because you've registered your medical information there. So if you have a portal account, I would definitely go and check it out. And that's my main tip. But it was very effective for the 2 folks I know who are over 80 in terms of getting the first initial dose really quickly.
Terrific. Thank you so much. Well, the next question has to do with our own group here, our age-friendly advisory group. We have been in place since 2015. We are quite a good network, a strong network. What can we do to support the efforts of National Agency on Aging and National Institute on Aging and National Institute on Health?
So I think there are 2 key things that I touched on in the presentation. One is to help address the spread of misinformation. And I say this because I've heard this among my friends who are people who should essentially know better than to say what they're saying. I've heard people say that the vaccines are getting integrated into your DNA and they're never going to leave, and just complete kind of craziness, not scientifically based. So to the degree to which you can share content from the CDC pages, that HHS, the Health and Human Services, that COVID landing page. I can send you guys a range of links where you can get information, pull it out, and share it. NIH is producing a lot of that content, but to the degree that you can distribute that information, particularly to communities of color, other vulnerable populations, people who maybe are getting a lot more misinformation, maybe who are going to be very reluctant to do things like go get a vaccine, join a clinical trial. That's tremendously helpful, because we can't do that without help from the communities. The second thing is really to communicate to folks that that we do need people to partner with us in clinical trials. We do need people to, whether they've had COVID or whether they have not had COVID, to consider joining one of our clinical studies. And I can send you guys the links again, but they're in the slides. Go to those landing pages, and they make it quite easy, because it's basically on the main page. You just kind of click on, join a clinical trial, and it'll take you right there. So those are the two things. I think education and participation in clinical trials are going to be key, not just for us at NIA, but also for NIH, particularly the Dr. Fauci's Institute.
Terrific. Thank you so much. Two follow-up items for us as an advisory group. Excellent. The next question is, are the vaccines that are not yet approved being manufactured before approval?
Yeah, this was, my understanding is this was an unusual thing that was part of that Operation Warp Speed, getting, vaccine doses, millions of vaccine doses ready for distribution in a super short time frame by this month, essentially, in essentially 1 year from when we had the first case of COVID in the US. In order to do that, the federal government had to invest in production of vaccines that did not have that emergency use authorization yet. And so it was a risk in terms of a financial investment, because if you pay for the vaccines, and if it didn't get the approval of the FDA, the EUA approval, then it could have been a waste of money. But it was something that I think the federal government felt they had to do, because otherwise, if they had waited until December, when the FDA made their decisions on the first vaccines to start manufacturing, I don't know how long it takes exactly, but you could imagine that to get millions of doses, we would be months behind now. We wouldn't even be beginning to vaccinate people, because we wouldn't have the stock. So that was something that was part of Operation Warp Speed.
Terrific. Thank you. Next question for you is, do we know if a vaccine can result in a positive COVID test after you have been vaccinated?
I don't know for sure. I don't believe so. But again, I can check on that and get back to Lily Fisher.
I can step in with it. First of all, thank you, Dr. Kelly, and I apologize for having to step away for a moment. That my life is all COVID all the time. So, but the answer is that the way the vaccines are designed now, they are not designed around active virus, the RNA parts of the active virus. They're protein spikes. It's a piece of the virus that we're training the vaccine trains your body to detect.
Right.
That piece of the virus is not capable of giving you the virus. That's the simplest explanation I can.
Thank you, Dr. Crowell. Terrific. All right, let me see. I've got one more question here. Do current studies need to have placebos? That means that half of the participants have to go 2 years without a vaccine, while everybody else is getting vaccinated.
Well, that's a tricky question. I can't speak to the design of the current studies, but I mean, most clinical trials are placebo controlled. They have to be, or you can't determine whether your particular intervention has worked or not. But it probably depends the length of time that a person would have to go if you got the placebo to go without a vaccine is probably going to depend on the endpoints they're using, because the way some trials are set up, eventually they roll everybody in the placebo group into the treatment group, and it could be that if they have relatively early time points, a person might not have to go 2 years. But I don't know. I can't speak to the design of the different studies because there are several of them. But it is certainly possible, because you do need placebo controls for clinical trials, or you basically need a standard of care control. And in this case, we didn't have a therapy before for COVID.
That clearly plays a big role in a person's decision to participate in a clinical trial or not, clinical study. All right. Next question is the vaccine safe persons who have an autoimmune disease?
That is a physician question, and I'm not going to attempt to answer that. I will tell you, and I'm happy to share it. Just this morning, I got an update from the New England Journal of Medicine. They have a really excellent question and answer page. It's designed for physicians, but it's actually pretty reasonably like lay audience friendly if you know something about COVID. So I'm happy to kind of cut and paste that for you guys to take a look at. But I would say that, individual case by case situation, talk to your medical care provider because I don't know that anybody would make a blanket statement about that. But since I'm not a physician, I don't want to comment.
Sure thing, thank you. All right, I don't see any more questions in the chat box. So Dr. Kelly, thank you so very much for sharing all of this wonderful information with us and for your willingness to follow up on a few questions that we have. And we are delighted that you are a resident of Montgomery County, and we hope to continue to engage in conversations with you in the near future.
I'd be happy to. Thanks so much.
You're also welcome. And so thank you. This is a part of the thing that I don't like on Zooms because we cannot really show our appreciation to people. So thank you so very much. So we are going to return back to our agenda, and I see that our co-chair, Director Robin O'Reilly from the Recreation Department has joined. Robin, would you like to share some greetings and salutations and or updates to our group?
Sure. Sorry for my tardiness. I was on a county council session and it ran,
no worry at all.
It ran long. So sorry for jumping in late. Thanks. Good to see everybody, even if it's virtually. Appreciate everybody jumping on the meeting today. And that was a great presentation. I really enjoyed the second half of it that I got to listen into. So thank you. In terms of an update for recreation, much like Raymond, we're all about COVID. So we continue to help staff both testing and vaccine sites now. We're excited that we are going to have the opportunity to open up some of our very limited recreation centers starting February 1st for appointment-only fitness activities. So we've identified a plan to have residents be able to go online and sign up for a 50-minute fitness room, or maybe between 2 and 4 in the fitness room at a time. But we'll also have time slots for walking around the gym if you want to walk around the gym, some fitness activities, fitness classes in small group. We're also, I know everyone will be excited to be able to do some pickleball inside our gym, even if it's just for singles, no doubles. Again, by appointment only. So we're excited about that. So hopefully we'll be able to get that launched really quickly at about 8 rec centers spread around the county without impacting, Raymond, no worries, not impacting testing or vaccine sites. So we're excited about that. We're still doing the senior meal delivery. I mean, Sarah could probably jump in on some of this. We're still doing that every Wednesday. We have a partner that we're working with over in the East County that we help on Friday nights and Saturdays with the food distribution. We have about 15 now on food access calls. They're full-time there answering food access and rental assistance calls. We have 2 staff at 311. We still have about 10 staff at the Board of Elections. They're wrapping up their work there. They'll be finished this Friday. Will be their last day and they'll return to recreation work. Yay. And we still have some folks that are working at the shelters, supporting that work. So that kind of it in a nutshell for recreation, and I'm happy to answer any questions.
Robin's staff is HHS co-staff now. So thank you, Robin. For
you're welcome. Yeah. We're happy to help. We feel like we're one arm in Board of Elections for a while, and now the other arm's over in HHS. We actually have a couple of folks in the warehouse over at HHS also helping with the distribution of supplies and materials there. So we're pretty. It's our supervisors and managers. Sarah, big shout out. They do all the work, scheduling people, keeping tracking the potato codes so that we charge things to the right FEMA accounts. It has been quite the journey and quite the juggle. So I'm thrilled that we're opened up rec centers just to be able to get back to some of our missions. So big shout out to our staff who do all the work.
I was going to ask, you got rec centers? I want their addresses. Let me have the.
We will send them to you, Raymond. Yep.
Robin, thank you and your team for this unbelievable effort for almost a year. Oh my goodness. So thank you.
Not me, all them. So
and the
thanks.
team, yep, and the team. Dr. Kroll, would you like to provide a similar update for the HHS perspective?
Sure, and I will go straight to the issue that is burning in everybody's hearts and minds right now, and that is, of course, COVID-19 and vaccination. And it is a ongoing and constantly evolving story around this for us. Folks know that we have, for the governor's order last week, we were directed to begin opening up the process for vaccination in category 1B. And that is begins with folks who are 75 years or older, and then a series of other groups, and I'll go into those other groups if as needed. But the challenge for us, of course, is at the same time that they were saying they wanted us to do that this week, and then to open up to another group, the 64 and older, the following week, is that we are receiving very few doses of vaccine. In fact, I had to stop off. The reason I stepped off was to talk with someone about how we've been receiving vaccine. So we started on December 23rd with 100 doses, and each week the numbers went up. First week was 100, second week was 4,000, the third week was 700, I should say. And then the fourth week it dropped to 6,700. This week we are at you'll see two numbers. You'll see about 11,400 as total doses, but you will also see us talking about 76 or 7,700 doses of vaccine. From this point forward, all the doses we get are divided between first doses and second doses. So we received this week some 4,000 odd doses that were second doses, and the balance of those doses of that 11,000 number were for first doses. So if you imagine that the 75, the tier 1B, just in seniors that are older adults that are 75 and plus, numbers something in the order of 70,000 people. So at 7,600 doses or so a week, it's going to take a long time to get through all the people that are in the 1B category, in that 75 and older category. At the same time, we started with 1A category, and those are primarily healthcare providers, because we need those folks healthy and well, both to help vaccinate and to help continue standing up testing and provide primary care to folks. So we've continued vaccinating in 1A, even as we start in working on the group 75 and above. We started our pre-registration process this week, starting I think Friday, and we now have something on the order of 70,000 folks that are pre-registered. We will start vaccinating. There's an announcement that will be coming tomorrow. So the intent is to start some vaccination process in the week coming. There has been a lot of confusion about the vaccination process that I won't bore you with right now, but suffice to say it's a challenge system in part because we don't have adequate doses. The governor has talked about using the Southwest model for vaccination. So we vaccinate 1A, now we're vaccinating 1A and 1B at the same time, so we can continue that process. The model breaks down when you stop to think about Southwest Airlines boarding an airplane. They know exactly how many seats they have, and they're not boarding more 1A and 1B or any other row that exceeds the number of seats they have on a plane. Right now, we don't have the seats to vaccinate people, and that is an ongoing question, a concern for us. We're hoping that the new administration in Washington will be able to do something to accelerate the pace of vaccinations, our receipt of doses. The state right now is receiving about 70,000 doses a week for vaccinations across the entire spectrum of vaccinations. That includes vaccines that are going direct to nursing homes and long-term care facilities, and vaccines that were going to the hospitals to vaccinate staff and primary care and medical staff at the hospitals. We are working as we speak, pretty much continuously with the hospitals, as they finish up their vaccinations of their staff and healthcare professionals, there should be an opportunity for those remaining doses, any unused doses, or for their allocation to shift to cover the next tier of folks that are being vaccinated. Dr. Gales and Dr. Bridgers and Dr. Stoddard and I have been in conversations with the hospitals about how that transition will take place and what will happen. So we are not yet there. Our goal is to stand up more places where we can have people sit in a chair and get an injection, and get more doses to those places so they can go into the needles to get those injections. So that is the biggest sticking point for us right now. Sticking point, no pun intended, I'm sorry. The rest of what we're working on is about how do we get people to those chairs, into those chairs. So what are the issues in terms of how we pre-register folks and how we get them scheduled up? What are the challenges they might face in going online and accessing a computer system to get them pre-registered or registered? And what are we doing, working on in the way of transportation, or getting folks who might have some challenges in getting from their home to a vaccine spot? We're very aware that there will be some people that will have challenges, mobility issues. So we're working on conversations. We're having conversations, and Dr. Brunetto has been involved in some of those around transportation issues to get folks to a vaccine site. We're looking to see where else we can stand up vaccination sites as we go forward to make sure that it's close to where people live, as close as possible. And down the road, as we continue to unfold this vaccination process, we will be looking to see whether or not we can create more mobile options for us to be able to do vaccines. That is a function of dose and capacity to vaccinate. The state is beginning to stand up a couple of additional things like I'm told that we're informed that Giant stores, 3 or 4 in the county, will be offered very limited doses of vaccine to begin with. So something on the order of 60 a day, but they'll be able to schedule people to come in to get those vaccinations. And if that works well, they will likely ramp that up and increase the number as more doses become available. I think, what else do I want to say to you? That we are also mindful about hesitancy. To Dr. Kelly's, if you listen to Dr. Kelly's presentation, she talks about the hesitancy and the concerns, and some of your questions reflect some of those concerns. Basically, to message people, to give folks information about the vaccine that address those issues, to give them some sense of good information with which to make a decision about getting vaccinated, hopefully in the direction of getting vaccinated. And we're also pushing out information wherever we can to make sure that people are getting constant updates from reliable sources on vaccination. I want to talk today a little bit about an event that people are going to see in the news. We have a situation where we ask people to pre-register, and you can pre-register on the county website for vaccine. And the idea is that you pre-register, and as we get vaccine and using through an equitable process, we send people invitations to go and register in PrepMod. People have been taking those invitations to register and sharing that with other people out of turn. And so even though we were not ready we had not yet begun to vaccinate people who are over 75, a number of people showed up at a vaccination site. And so they are essentially out of anxiety and through not understanding necessarily the system, because there's some complications at the state system, jumping ahead of where they should be in that process. We've had some people who were probably in their 40s do that as well. In this last week, so it creates a problem for us in scheduling. And we went through we had a scenario today where we had more people showed up who were 75 plus, who had not yet really been invited to register to take the test. When I started this call, I was just talking with my manager at the testing site, who was saying they were working to accommodate everyone that had shown up, but we were really need people to wait before they jump into that registration site and start registering. It's going to be a while, and if people end up getting ahead of the schedule, once that starts, there's no stopping that. Then there's nothing to say that a 30-year-old can't register. And then we'll have 30 years ahead of 75-year-olds and 60-year-olds and 64-year-olds with immune compromised issues, with immune system challenges or health challenges. We set this up because we don't have enough doses to do everybody at once. And so we've had to make some decisions about prioritization. And so we'll continue to do that. So I'll end this way. Dr. Kelly quoted Matt Damon in The Martian and around sciencing the heck out of a situation. And I'll quote Matt Damon at the end of the movie, where he says, you solve a problem. You start by you solve one problem, and then you solve the next one, and then the next, and then the next. And if you solve enough problems, you get to go home. So that is kind of how we're approaching it in HHS. We solve one problem at a time, and then we solve the next one. Even when they come five at a time, we still try to solve them one at a time, so that we can one day draw a free breath of air without a mask, and that we won't have to worry about contracting this virus anymore. So I'll stop there and say thank you all.
Well, thank you so much, Dr.
Can
Crow.
I ask a question?
Yeah, if you could put your question in the chat box, there is one already.
I don't know how to do that. I'm sorry.
Oh, okay. But Leslie, that's fine. Go ahead then. You on.
Okay. If you pre-registered, are you eventually going to be contacted to sign up?
Yes. That is exactly the point of the pre-registration. Is to identify the folks that are.
So don't worry that other people have gotten ahead of you. You'll eventually get called.
Right. There is no, Florida and I think DC and other places might have done a first come, first serve registration. That is not how we're doing this. We're doing pre-registration, and then we will invite people in waves, because we want to make sure that there's an equitable opportunity to access this vaccine. This vaccine came at us in some particular communities and through some particular vectors, and it is still attacking this county through those same avenues. So we need to make sure that as we distribute vaccine, it's not just to those folks who happen to have a friend with a link who can connect you up, and it's not just those folks who happen to be watching the county government every day in and out, but it's the folks who actually are going to need it as well, so that we can.
So just be patient, and your turn will come.
Yes, and now I think yesterday or today, we changed the pre-registration site so that if you sign up, you should get a confirmation that you are successfully signed up, and you should get a periodic update through either whatever route you suggested, whether that's email or text message on your phone, or a phone call. The phone call might be a little difficult, but I think they're going to work that out as well. So we got somebody who can call them back and give them an update.
So if you signed up last week or 10 days ago, I haven't gotten anything. Nobody's gotten in touch with me.
So 10 days ago, we didn't have this system up.
Well, when you first got the system up, I don't know how long.
We got this
early on.
We got the system put up last Friday, about 5 or 6 o'clock, and the team made a decision not to put the automatic response process in right then as a feature of that system, because it would have delayed getting the system up. So they got it up, and now they're going back, so that if you have registered at all, you should at some point get an auto response. And that's the plan that our technology services team has put in place. So if that hasn't happened yet, give it a day, I would say.
Okay.
I'll just double.
Thank you so much, Leslie and Dr. Crow.
Thank you.
The next question I have is for those people who have been fortunate to get the first injection for the vaccine, and they are, of course, anxious to get the second dose. How much notice are going to get them so that they can get ready to go to get their second dose, and where are they going to get their second dose and when, obviously?
So you should get your second dose where you should get your second dose by the same group that gave you the first dose. So if you, not necessarily the same site, it's not required that you go to the same site to get it, I don't think, but you want to make sure that if you got Moderna the first time, you're getting Moderna the second time. You should not be mixing Moderna and Pfizer. If you are one of those folks in the last week who registered and went to Prince George's County and got a dose. This is for those, none of you all here, of course, but if anyone did that by any chance, Prince George's County has indicated that they will honor those second doses. So they will give you a notice about when it's time to come back for a second dose. PrepMod sends a notice to people that their second dose will be due in about 28 days. And through our system, we are sending out a notice to people that when you get to the 28-day mark, it's time to come and schedule your dose. So ahead of that, your 28 days, you should get a notice from us that says time to schedule your second dose. There is a window around this. It doesn't have to be exactly 28 or 30 days. So there's a window plus or minus 3 or 4 days. So, and maybe even longer in some cases. So I would not, if you miss that 28-day or that 30-day window, do not worry, get your second dose as soon as you can after that 28-day window.
Terrific. Thank you, Dr. Carl. I got a follow-up question to the previous issue we discussed. When people pre-register for the 75 plus and they don't hear anything from public health, what should they do?
If you have pre-registered, I'm going to get myself in a lot of trouble with my technology services team. I'm going to send them a note while we're talking and see if I can get a quick recommendation from them on that. My inclination is to tell you that if you haven't heard, you may want to pre-register. You may want to re-register, only because one of the things that we're discovering is that there are some emails and a couple of phone numbers that might have gotten transposed. I've put my email in raymond.kroll@montgomery-county, blah, 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 blah. And every time I start typing it, I end up transposing a T and an M or M and an N. And I set myself up to get nothing from people. So it may well be that you could inadvertently have entered a digit inappropriately, or for some reason it didn't get captured in the registration. So I'm going to confirm that while we're talking, but before we stop, but I'm going to ask my team real quickly what their recommendation is around that.
Terrific. A million thanks, Dr. Carl. All right, I don't see any other question at this moment in the chat box, so I think we're going to go back to the agenda. And I see that my name is on the list for budget discussion. So my first question is anybody from OMB on the call? And if not, I will talk about budget. So, okay, nobody from OMB. All right, so regretfully, this current fiscal year, FY21, we have had to do a savings plan, which is a way to reduce our budget in order to meet our revenues and expenditures. And we did that back last year, early fall. We are regretfully in a place where we need to take a second round of budget reduction for this fiscal year. And what I understand is that the proposal from the county executive for budget reductions have been forwarded to the county council. The county council members are going to review those proposed reductions and discuss them, and then of course they are going to vote on it. So I have reviewed the list, and of course we'd be glad to share with you the list of proposed reductions. Many of them have to do with delaying hiring of county employees in order to save salary funding, so that we can, save funds that way. My understanding is that the gap that we need to fill this current fiscal year is $133 million. So amongst all of the agencies of the county government, that's what we got to come up with. And for aging and disability services, we have had some adjustments in reducing some programs where we have had less utilization because of COVID. People do not come to our meetings, obviously, because we don't have any face-to-face. We provide services in the home, and some people are fearful and don't want that. They want to delay it until after the vaccine are arrived. So we have a couple of those reductions for aging and disability services. And one of them I know affects one of our contractors right here on the line today, and that is the Jewish Council for the Aging, the program that is called InterAges. The proposed reduction is $15,000. InterAges is a program that matches trained volunteers with school children who are in need of extra help. It has been extremely successful for decades, and I know the founder of the program, our wonderful colleague Austin Eman, is on the line, and I'm sure he's distressed to hear this, as well as is David and our JCA team with Shane. So the county council will discuss all of those items. We do not have a date as yet of when the hearing will be. Obviously, as soon as I have that information, I will let you know. So let's see if there is any questions on the budget situation. And then I see in the chat some additional questions related to the vaccine. So put your questions in the chat box, please. And let me read the questions related to the vaccine again. The whole Prince George's County clinic situation was very confusing for a lot of people. I think Montgomery County assumed that it was okay because the state of Maryland website directed them there. I assume the system would just cancel appointments if the system hadn't gotten to our priority group as yet. So,
So am I still? Yeah.
so Raymond, back to you because I do not know the answer to that.
Dr. Kelly, that it was confusing to all of us. And the system as it was structured, that system was designed for, has been up for years, and it's been designed for just immunizations in general for people to sign up. So if you want a flu vaccine, of which there are hundreds of thousands of doses, it's designed to just let you go in and sign up. They added, for reasons we still don't fully understand, COVID to that, and posted schedules, known schedules out in the county. Prince George's posted their schedule, and I think decided to post their schedule through I think into February the 9th, and it did not apparently track or limit people's access to sign up by tier or priority group. It simply accepted whoever came on a first come first served basis. So you could look and see 300 doses in Prince George's County on January 28th, and then look back a half an hour later and see 0. And it just that's how they ran down. We had a conversation with them over the weekend, and I think that led to a press conference about County Executive Elza Brooks, and she announced that they were going to honor the scheduled appointments up through the 9th, but after that they were going to a pre-registration system, essentially just like ours.
Yeah, that's what I heard, but boy, there was so much confusion. I mean, even including friends of mine who are physicians, I think they were directing people to that site, and I just figured we would get canceled if they weren't to our group yet. So I thought it was just kind of a crapshoot in terms of timing, but it didn't make any sense because why would they were sending us to Prince George's County without checking our residency? But thank you, that's helpful to know. I will share that with my neighbors.
Okay, and if they did sign up and they got accepted, they got an appointment scheduled, Prince George's will honor it, and they will also honor second doses. So
okay, thank you.
Right, thank you so much. All right, well, I see that we have about 30 minutes left on the clock for our meeting, and we still have lots of wonderful conversations to be had. So this is the time now where our wonderful work group are going to report about what's happening with their teams. So I'm going to go by alphabetical order. So I'll start with civic and social engagement. And so Vivian and Kathleen, if you could let us know what's happening from your point of view.
Actually, Austin's going to report for us.
Oh yeah, all right.
Well, we are going to actually meet, the three of us, on Friday to pursue this, but there was an interesting article in close to the Times about aging in Japan. Some of you may have seen it, and it referred to the sense of purpose being important. And for those of us who are retired, we can probably relate to that. we're going to consider how we may revise our governing documents to include not only social isolation, but purpose. And may not change some of the activities, but it's an important point to make. And we also haven't met in a long time, so later this winter we hope to gather online and pursue some of these, get an update on where we are with everything.
Thank you. Perfect report. Thank you so much.
Odile,
Yeah.
I would like to add that we've just opened the nominations for the Neil Potter Path of Achievement Awards, which recognizes lifetime of achievement. And I want to acknowledge Stuart, who's once again on board to support the program. He'll be running an ad for us for nominations in February. And also Commission on Aging, who have always provided esteemed judges to judge our nominations. So I'm encouraging everyone, I'll send a link out to spread the word to encourage people to nominate those lifetime of achievement people, older adults.
Well, let me mention one more thing. On the expo that Stuart the Beacon is running till the end of the month, there is a presentation on intergenerational programs in Maryland, which some of you, if you're interested in that subject, might want to take a look at.
Thank you for this great update. And Kathleen, is there a deadline for that nomination?
Yes, the nominations are due March 12th.
Yeah,
It's
all
probably
right.
going to be virtual again this year as it was last year,
Right.
but March 12th. And I'll send the information to the.
Terrific.
Thank you.
Thank you, Kathleen and Austin. Thank you. And Vivian too. All right. Next group is communication and outreach.
Yes, and for a change, I actually have a report to give.
All right.
First of all, thank you, Austin, for the call out about the Beacon Expo. It only runs, as you said, till the 31st of January. So if you haven't had a chance to look at it yet, there are dozens of classes and speakers and entertainers, as well as, of course, all the exhibitors to look at. And it's totally free. Tell people they have another few days in which to do that. As for the page in the Beacon, thanks to Odile and Barry Hudson of the Public Information Office, our task force now has the opportunity to produce the monthly age-friendly page ourselves for the Beacon. As you know, since Lorraine changed departments, we haven't had any staff at the PIO to provide the content. So now Marcia and I will be working with many of you in the next few weeks to produce age-friendly related content for the Beacon. Our plan is that every domain will have at least one chance a year to own the age-friendly page. We envision a newsletter format with 1 or 2 short articles totaling around 350 words, plus a photo and caption, and then a COVID update box from the PIO. We'll be asking about a dozen of you to write up in the next few weeks a basic age-friendly related article about some aspect of your subject matter area, whether it's about senior transportation options, public safety basics, resources for getting back in the workforce, affordable housing and home share options, whatever you think is most important for county seniors to know about county and community services in your area. We'll then work up a year-round schedule, giving each of you a chance to update your basic story a few weeks before we print it, and the opportunity to add a few items of upcoming events or programs that Beacon readers should know about. Now, Marcia and I want this to be as painless as possible for you, but we'll need your assistance to gather the information soon so we don't find ourselves in the position of scrambling at the last minute for content. We hope you'll all see this as an opportunity to get publicity for all the good things you're doing with your teams, and that you'll help us make this new age-friendly page in the Beacon as helpful as possible. If there are any questions, you can let me know.
Fantastic. That is quite a big message. Hello. Fantastic. And thanks all of the work group in advance for putting the materials together so that we can share all of that good information with all of those who read the Beacon or look at it online. Anything else from public communication and outreach? We good? Okay, great. All right. Elder abuse prevention. Do we have somebody from State Attorney's Office or Adult Protective Services? Not at this time. Okay. I would just say from Adult Protective Services, I think last time we met 3 months ago, I mentioned that we'd had a drop in referrals in APS. That is no longer a problem. We are now back to our pre-COVID number of referrals for APS. So I don't know if that should rejoice or not, but obviously, it's reassuring that we are getting referral again in the same amount as we were before the pandemic started. Employment, Mara and
Okay. I think I've got most of it.
okay.
For start, I'll go through a couple of items. We're having some changes in the membership of our work group. As many of you know, David Gamzee has stepped down as the head of JCA after, I believe it's 30 years or a smidge longer. And he's officially stepped down also as the co-chair of our employment work group. I should add that while we understand that, we are all working to encourage him to stay on in the group, even if it means wearing a different hat. So please help me, encourage him.
Yeah.
Yes, David, yes. Clearly there needed to be another co-chair. I'm the other co-chair, obviously. And so I'm very pleased to report that Cynthia Grissom, who's the Director of Business Solutions at Services-Montgomery and has been on our group for several years now, and she really understands these issues, agreed to step into the role. So we're just delighted about that. That's a great move. The group is also looking to expand its membership, and we now have one new key addition to announce, and that is Steve Greenfield, who oversees workforce development and continuing education at Montgomery College. Given the importance of helping the 50 plus keep upskilling and reskilling, those are words you're going to hear over and over again in these next decades. In this changing technology environment, what you learned 20 years ago, no less longer, is not up to date. So clearly having Steve on board with our group is a great step because Montgomery College is a leader in that area. And we are working also on attracting several other people to the group, and we will report that when it happens. Second, in these crazy COVID times, the work group is still encouraging and tracking efforts to improve employment for the 50 plus. The JCA Career Gateway program is doing well and has had several cohorts since our last report. And JCA has been holding its 50 plus employment expo virtually also. And they are reporting good attendance in terms of both job seekers and potential employers, which is pretty amazing. So just to give you some sense of what they're up to, there are expos virtual for employment planned for February, March, April, May, and June. You can go to the website and get the details. It's pretty amazing. So that's moving. I should also say that Services-Montgomery is offering many of its programs virtually. For starters, they have workshops on a variety of tech concepts. They've got a program called Tech Tuesdays, and they do workshops on all sorts of techie things, but they also have other workshops going. So one of the big issues is always how to revamp your resume. Another one that they've got I thought was interesting was interview expectations. Not something that you normally have people help you walk through, but it's important to have your expectations appropriate. And finally, I just say that we are really looking for ways to reach out to employers to educate them about the value and the benefits of the 50 plus employee. One of the things in the works is that Jim Stowe is working on a special virtual presentation, which we are hoping will attract employers to attend, because after all, the drive is not very long. So that's moving. Yeah. And lots more, but that gives you a sense of some of the key things. Life goes on even in this insanity. It just amazes me. That's it.
Thank you. Thank you for your amazing report. And thank you, David and Mira, for having fantastic co-chairs of the employment work group for all these years. And clearly we want to welcome Cynthia Christen now as the co-chair. Thank you for your willingness to take that role. And also wanted to give kudos to David, who has received a special proclamation this week, from County Executive Mark Elrich and the County Council for his outstanding contribution to our age-friendly initiative and many, many more programs serving older adults and their families in our county. So kudos, David, and enjoy some wonderful time off. And don't forget your plans in age-friendly Montgomery. So at this point, I'd like to switch over to the Health and Wellness Group. And we are also welcoming a new person in that group, and that is Dr. Patrice McGee, who has been hired as the new Area Agency on Aging Director for our department. Patrice started, I believe, maybe 2 months ago. And she is jumping in there with both feet and both hands. And she's partnering with Sarah Swar from the Recreation Department for our Health and Wellness work group. So Sarah and Patrice, it's all yours.
Okay, I'll go ahead and start. Thank you, Dr. Bernardo, for that introduction. And like you said, I've been with the AAA now for 2 months, so I successfully.
Patrice, could you come closer to your microphone?
Yes, so my audio comes in rather slow. Is this better?
Not too much, no.
Really? Let me see if I can do some adjustments. Okay, is that better?
Yes.
Awesome. All right. So I successfully co-chaired my first Health and Wellness Committee meeting on Tuesday, the 19th. And it was well attended. There was about 13 participants, and we had 2 presentations. The first and the lengthiest one was with Livleen Gill from the Bethesda Nutrition and Wellness Solution. She presented on social isolation, as well as innovative nutrition and food security. So they had this new program project that they have launched in partnership with the Department of Aging, the Maryland Department of Health, and several other groups to address connecting the community, connecting healthcare to community-based organizations through technology focus with a focus on connecting seniors. So the model, the design that they use is to combat isolation and to provide medically tailored meals, nutrition, education, and nutrition education for those with chronic conditions. And they're doing this using a user-friendly, non-Wi-Fi, low-tech tool to order meals through local co-ops and restaurants. So they're wanting to partner with the AAAs. So we do have a upcoming meeting with them in a few weeks to just discuss the program a little bit more and figure out, you know, what type of partnership they're looking for. But it was a very informative presentation. And also in an effort to bridge the connection efforts of multiple groups that are focusing on social isolation. David, our second presenter, was David Engel with the Commission on Aging, and he talked about the COA's health and wellness approach to social isolation. So it was a very robust and informative meeting. So, you know, I know that's one of our focus areas, so that's what we focused on this particular meeting. And then Sarah, if you're on, I thought I saw you, if you want to talk about the initiatives of the rec department. You're on mute, Sarah.
Thank you. Good afternoon, everyone. Yeah, so after the presentations, we just talked about some of the opportunities for the older adult population in Montgomery County that the Recreation Department is offering. We talked about our current virtual offerings that are going on now during the winter months, but how we are also in the very intense final edit process of our spring guide, which would hope to have a combination of virtual, in-person, outdoor, and maybe a few indoor programs, depending on where we are in the restriction process. And And we also mentioned about fall prevention because we want to make sure that we ramp that up this year since that is one of our data points. We wanted to start that conversation early, and that conversation will start continuing as September gets closer.
Fantastic. Thank you so much, Sarah. Let's go to the home and community-based services. I see Lily Fisher is online. Lily, if you can take the mic.
I am going to pass this over to Hilary Zumba, who is our chair, because it's wonderful to have her here today, and I thought it would be awesome for her to be able to provide the update. So Hilary, it's all yours.
Thanks, Lily.
Thank you,
But
Lily.
certainly jump in if there's anything I miss. The Home and Community-Based Services Committee last met at the end of November. And there were some great milestones through 2020, challenging year as it was for all of us. But one of the big accomplishments was production of a number of Engage at Home videos. And I'm going to put the YouTube link to those in the chat with an invitation to all of you to please promote and share those videos, which provide a lot of information. It's a 13-part series, and they provide a lot of information about opportunities for people who are at home to still find the support that we know many caregivers need for themselves, family caregivers need for themselves, as well as opportunities for those that they care for. So please check out those videos and share them with others who might be interested. The other considerable topic of discussion was defining the focus for our 2021 work, which will be around workforce development, recognizing that even before the pandemic, there were significant workforce pipeline challenges in terms of caregiver support for home and community-based services, home health, care, long-term care management, and so on. And so that has all been compounded by the pandemic and the impacts of the pandemic on the workforce and individuals and families. So that will be the focus of the committee's efforts going into 2021.
Terrific. Thank you both. Yeah, that has been quite a challenge for many years, and the challenge has increased. So really appreciative that your group is interested in tackling this issue. Thank you so much. The next group is housing. So Leslie, I don't know if you want to report. Hi, Leslie. Yeah, you can unmute yourself.
Okay, now can you hear me?
Yeah, we're good.
Okay. Okay, I've been working with the managers of senior living, independent living, affordable senior living communities. They are very concerned about the delivery of vaccine and getting it to their residents. They are independent living, they are not assisted living, they are not nursing homes, they are the crack. But the people that live in these communities, many of them are frail, and they do not, and they cannot easily get around. They don't drive, and it's difficult to take public transportation. So I've had many inquiries from the management as to whether or not arrangements could be made with a vaccine provider like CVS or Giant or whatever to come to these communities to deliver the vaccine. The other concern about that I get from the management of these communities, they are in constant contact with their residents. Their residents, we know, are high risk. Are the management activities directors eligible to get vaccine as care deliverers, care managers, care deliverers to these senior communities? I don't know the answer to that. I don't know if, who would have the answer to that. But those are the concerns of the people that I'm working with on a regular basis. On a more upbeat kind of fun thing, We're working on a next group of webinars for our managers of affordable management, the team of affordable management with, and one of our partners is Montgomery College, and they do give a certificate to people that take these webinars. And we're going to focus, our focus this time is going to be on technology and how, and sort of a train the trainer, how to train the managers to train their residents to be more able to use technology. And I have been in touch with Senior Planet, and I'm hoping they'll get back to me as one of the speakers. So that's what I've been doing.
Thank you so very much, Leslie. And I just, back to the independent apartments, I am in daily communication with our public health partners in HHS, and clearly we have the same priority folks on our mind. We are discussing how to address the needs. I see Dr. Crowell is still online. Dr. Crowell, would you like to address this planning issue?
What I like to address this, what I would love to be able to say to folks is that, he's here in quantity, and let's just get it done as quickly as we can and everybody come in. I think that we're aware of the community, and I think we've heard those concerns. I think Odile has expressed them with our public health officers, and we've been in conversation with them about them with the state. And as vaccine becomes available, we're going to have to move through groups around this. While we've been on this call to see, the governor just held a press conference encouraging and prodding, it seems, to get the schools to reopen by the 1st of March, and which means now that there's a question about schools being able to get their teachers vaccinated so that they can get the students back in again. So every time one of those announcements comes down the pipe, it forces us to recalibrate with no increased supply, who's in the queue. The school system, right? The educators right now are in tier, for us are in tier 1B, which comes after adults 75 and older. So that means that we've got to start thinking about how do we vaccinate them. So the long and short answer is understand the concern, not in the short run around that. Are we going to be able to accommodate folks who are in close proximity to folks who might be at some risk? I would say this to you, that encourage people to continuously stay safe and really double down on protecting oneself. Masks, social distance, hand washing, etc. It looks to me, just looking at our list, that we may that number, that group may be become eligible in priority 1C, maybe, and that's just a guess on that for me right now, because it is changing continuously. But that would be a while yet, given our current availability of doses.
I'm happy to help when the time comes.
Thank you, Leslie. I should tell folks that one of the things that we're doing is that we're not waiting until we get doses before we start trying to solve some problems. Odile has been working, and we've got a group that is working with and is working on bringing community partners to the table to talk about the challenges of each tier, each group, as we get deeper into the group. When we start vaccinating folks who are 75 and older, there are groups of folks who won't have any trouble getting to us, and I think, and getting vaccine. As we progress through that vaccination process, we've got to begin to stand up strategies to help folks who are going to have to struggle. So transportation is an issue. Point of care is a question for us. And as we move through all those groups, I think, are there communities where it makes sense for us to go and stand up mobile solutions? We're going to need the community to help us do a couple of things. One is to aside from educating folks, the other one is to identify the problems that each group is going to have, and then help us figure out a strategy that solves them. And the third thing is to help us implement that strategy, so that we can collectively get ourselves out of this pandemic.
Thank you so very much, both Dr. Paul and Leslie.
I'm going to tell my people to just be patient. They're not
Yes.
forgotten.
tell your friends, your colleagues, your parents, your grandparents, your peers, please be patient. This is just going to take us some time to work our way through this.
And so we right now have over 53,000 older adults over the age of 75 who are pre-registered. So we started that on Friday last week. So this is a great accomplishment. Again, over 53,000 people registered over the age of 75. However, in our county, we have more than 73,000 people over the age of 75. So we still have quite a number of them, over 20,000, who have not yet registered. So this is our focus right now. And clearly we understand that many of the folks are going to have challenges with transportation. And so we are discussing with public health some ways to address that successfully. I think now I'm going to move to the next group, which is planning, open spaces, parks, and community building. Is there someone from the Parks and Planning Commission online with us today? Okay, if not, I just want to point out that the Park and Planning Commission is working on their initiative called 5 Montgomery 2050. And everybody is welcome to provide their input online and or send an email with your comments, etc. And in the chat box, you have the address and the email address where to send your comments related to this initiative, 5 Montgomery 2050, that clearly will affect all the adults and their families. Next is the senior public safety. Is someone from fire rescue or police online?
Actually, Jim Resnick from Fire Rescue, and I'll let Jim McClellan from OEMHS jump on if he has anything to add. Very quickly, we just met a couple of weeks ago. We are planning on having a community safety forum, and the idea behind this is it will be not just for seniors, but for seniors and their family and their friends. We're looking to do this as an hour-long presentation in early March. We'll send out notices to everyone. It'll be an open type of an event, but people won't be able to ask questions. We'll have to just do it through chat, probably on Zoom or one of those types of platforms. And it's going to be Office of Consumer Protection, Office of Emergency Management, Homeland Security, Montgomery County Police, Montgomery County Fire, and we also plan on asking HHS to be included in there. The whole thing is going to be an hour, so it's just going to be kind of an update on what folks can do to keep themselves and their family members safe through COVID and beyond. Above and beyond that, we welcomed our new member to our group, and I'm forgetting her name right now, but it is the new Montgomery County police officer who has community outreach, and I apologize for forgetting her name right now. I don't believe she's on the call with us today.
Jim McMarsh, I think her last name is Flynn.
Yes.
Okay.
I think. I'm seeing Jim McClellan shaking his head yes, trying to pull me out of that. So I apologize for that. She's wonderful. She's going to be engaged with us, and we're looking forward to working with her. And then finally, we are also looking to have, and I believe it's in February, but my notes are not in front of me right now, an internal for, this would be an internal thing for folks from the agencies and departments that are involved in the public safety group, so that we kind of have an update as to what each other's departments are doing in terms of senior safety. This is a follow-up to an in-person program that we had back in 2016. We looked at the calendar and realized it had been 5 years, and it's time to do it again. So that's my report. Thank you all very much. Stay safe.
Thank you, Jen. I also want to point out that regretfully we had a horrendous fire at Leisure World about 2 months ago, and we are so forever thankful to Fire and Rescue and others who have assisted close to 60 residents to relocate to a hotel and recover from the fire. Regretfully, we had one fatality, one older lady that died in the fire.
It was
So
a very horrible situation. And Odile, as you say, the fire department, of course, we're the ones that put out the fire, but the response from the broad swath of county agencies, from Emergency Management and Homeland Security, from HHS, from the Crisis Center. I mean, the list goes on and on and on, permitting services and the like. You know what, when the chips are down, people show their true colors, and it's quite remarkable. And I will mention, since you did say that, we have had an incredible spike with residential fires, especially the last 2 to 3 weeks. So please, as you talk to your friends, family, neighbors, and so on, tell them practice fire safety, please. Thank you.
thank you, Jim. And so this March event will be very timely and super helpful. So thank you in advance for that. I just recognize that it's 5 o'clock, and some of you may have other commitment, and we clearly understand that. But if you don't mind, we have a couple of more items, so I will continue for those of you who are able to remain online, and I appreciate them. Thank you in advance for that. Jim McClellan from Emergency Management, any updates from your end? You're on mute, Jim.
Okay, I'm sorry, what was your question?
Do you have any updates from your department?
No, just that we're going to be working with the other members of the group to pull together this town hall. So.
Great, thank you for your partnership, of course, thank you. All right, moving to our next group, Transportation and Mobility. I see Sean Brennan and Sam Oji.
Here, just give them J1. Hi, Odile.
Hi,
Thanks. Just a few things real quick. We are still continuing COVID-related ride-on operations, mask requirement, and we are distributing masks on the buses. Fares are still temporarily free. The enhanced cleaning by the Department of General Services continues twice a day with hospital-grade cleaners. We are still emphasizing social distancing with limited capacity on the buses. So our 30-foot buses will have a limit of 15 riders, and our 40-foot buses have a limit of 20 riders. We are placing strategic buses at locations where they can be deployed immediately if any of the buses are nearing their capacity to continue those routes so that nobody misses their trip or gets late to their destination. And on that note, we do have some good news. We did receive $600,000 from FTA, part of their research demonstration grant. And this grant will allow Ride On to develop a platform that provides real-time bus loading and crowding information. This will help increase public safety and confidence to ride the bus. So in other words, as people can currently go to a Ride On real time and identify the location of their bus and how far away it is from them, they can also see how many people are on that bus. And that will help them determine if they want to ride on that bus, if the bus is getting to capacity and they need to make alternate plans. That same app would allow them to tap into whether it's other ride-on routes or Metro bus, Metro rail as an alternative option for that. But most importantly, this grant will allow us, and what we're calling this will be, it's a ride-on crowdsourcing system that this software will be. Central dispatch folks will have access to it, and it automatically relays to them when a bus is getting near capacity, and they can deploy one of those strategies that I'm talking about. And all of this is to increase the social distancing, which we want to maintain, reduce the spread of COVID by limiting the number of people who actually ride the bus at any particular time. So we're really excited about this grant, and we'll get working on that immediately. Now, we've had discussions, Odile, about transportation for people who are unable to afford transportation or don't have access to transportation to receive vaccines. And last week, FTA released a COVID-related $50 million grant, and a portion of that is dedicated to enhance the mobility for older adults and people with disabilities. We reached out to COG, who is the pass-through for these funds, because our idea there is to make these funds available for our older adults who need transportation to get to vaccines. We'll partner with our taxi cab companies and have them be able to transport those people to their vaccine locations for free. So that's what we're working on now. We're waiting to get the feedback from COG. They're waiting for directives from FTA. And as soon as we get that, we will implement a process in place where we can be, people can identify as they're registering for the vaccines whether they will need transportation. And that is somehow relate to us, and we can step in and assist in those situations. So, and then finally, obviously, we had a really successful virtual transportation options outreach event for older adults and people with disabilities, which was recorded. It's posted, and people are accessing that constantly, basically telling people about safe transportation practices during COVID-19, as well as the transportation options that are available to them during this period. So that's all I have for now. Sean?
Wow. Thank you so much, Sam. And I'll connect with you about this FEMA money for transportation to vaccination sites. That's going to be great. Thank you so much.
Absolutely.
And congratulations on the transportation webinar, which is so successful. So, Sean, back to you.
Yeah, I just wanted to give a little background for why I shared the Thrive opportunity to weigh in on the Montgomery Thrive 2050, which is the general plan. I looked today at, very skimmed it, their transportation chapter, and one of the visions of this effort so far seems to be to get more people walking and biking and taking transit, which are all wonderful objectives, but one of the strategies for doing that is making parking harder to come by and more expensive. And what I fear is that if that is taken too aggressively, that people, older adults who have difficulty moving, who just need to be able to park close to their destinations, will be kind of left out of some of our, transit center development, our shopping centers and so forth. I mean, we can't eliminate that cars are going to be needed for a certain percentage of our population. And so far, I'm not seeing much that is acknowledging the aging population in this context. So I just encourage people to take a look at the Thrive plan and to weigh in as you see appropriate. Thank you.
Thank you, Sean. Could you also let us know about, I think this upcoming weekend, there is a special session on pedestrian safety?
Correct. Yeah, this is a meeting that Councilmember Glass has organized, I believe, on Saturday, and an opportunity to look at Vision Zero and the development of the 10-year plan for Vision Zero, and that's all about ending traffic fatalities of any kind, and it's taking a multifactorial approach to that. So yeah, public involvement in that process is really important too.
I wanted to chime in while you're mentioning Vision Zero. On Saturday morning, Councilman Evan Glass, along with U.S. Congressman Anthony Brown, are going to be doing a Vision Zero online conference. So I put information about that in the chat, and if you can share that with anybody that you think might want to attend.
Thank you so very much, Dory. Yes, we will. I have two more folks that I would like to hear. I know they are not on the agenda. I'm going to put them on the spot. I hope you don't mind. The first one is Barbara Stelter, who is the chair of the Commission on Aging, and then Pazit Aviv, who has been working very hard with accessing food. So Barbara, if you would introduce yourself, welcome to our new chair of the Commission on Aging. And
Odile, your voice is just cracking up. Your voice is not coming through, Odile.
oh, I apologize. Thank you. Is that any better? Hola. Okay. So Barbara, the mic is yours. Welcome.
Okay. Thank you. I'm Barbara Selter, and I am the new chairman of the Commission on Aging, and I am delighted to be joining your group in that capacity. The Commission on Aging has been busy. We have been tracking legislation related to the villages, related to housing tenant relationships, and a number of other things. We're writing letters to legislators in support. Another initiative, we're beginning to plan our work on the public forum that we normally do in March, although we are thinking of postponing that a bit to May, and are looking at the topic of social isolation for the public forum. Additionally, we have two task forces that are working, one on social isolation and one on policing, dementia, policing, and racial equity. We are working on a report from that task force, and hopefully that will be coming up in the next few months. And let's see, I think that's about all. Is Jean on the line? She may want to jump in with anything I've forgotten.
I did not see her in the list of participants.
Okay.
Sometimes we don't see it.
Oh, one other thing. We are conducting interviews for hosts for the seniors today. And we're hoping to get that host in place. In the meantime, we are continuing with some repeats.
Right. Thank you for the update, Barbara. Thank you and the Commissioner for all your amazing work. So at this point, Pradeep, if you could give us an update about what you and your team are doing in the area of food access.
So the Food Access Call Center had been working on providing information and referral to individuals looking for any type of food resource, whether it is federal, state, or county, local solution, meal delivery, food pantries, SNAP information, and the like. And we have had pretty good success in training staff that hasn't had any background in food resources. We got people from recreation, thank you, Robin and Sarah, from libraries and some HHS staff. And on January 5th, a press release came out that promoted our public-facing self-referral form. And we have experienced a significant surge. So just to give you a sense, currently the total number of referrals in the system is at around 3,400 people. And since January 5th, we got 1,114 referrals. So we experienced a significant backlog and had to boost our capacities to respond to all these calls. That was quite the adventure, I will say. I am very happy to report that right now we are responding to calls that came in yesterday. So celebration time, we got to so many people at such a, serious crunch, and 330 calls of the 1,114 are for people 60 and over. Some are in multi-generational housing. So we've been helping a lot of people in the Latino community who live in 3-generation household. Some live on their own. And so staff has been really good about referring people to all the variety of food resources that are relevant to people 60 and older. And that's it.
Wow, thank you so much, Pradeep, for your amazing leadership and work and your team. And again, as you heard from Pradeep, the increase of people in need of food and the impact on all ages is just overwhelming in our community. So thank you for your outstanding work and all of the various partners from multiple departments in the county who are now experts in providing assistance during this crisis. So thank you a million. At this point, I see that I forgot a question inside the chat box, so I'm going to read it, and I think it's a question that Dr. Kroll may be very excited to respond to. Dr. Kroll, I'm going to put you on the spot again. The question has to do with the second dose of getting the vaccination. Is it up to the person to schedule the second dose? And if so, what if the appointments are all filled up when you are supposed to get your second dose?
So one of the things about that system in the state is that it fills up in first come, first served basis. When you pre-register for us, we will then send you a message to tell you that you're being invited to come and schedule your appointment. Once we've done that, we are reserving a dose and waiting on you to come and schedule. So you'll get some instructions on how to go to the system to register, and once that's done, some appointment options for when and where you can schedule your dose. So we are not putting out 400 doses and say first come, first serve. We're saying we've got 400 doses. We're inviting 400 people, and we're sending invitations to those people to come and register and get scheduled to vote. So at that point, it is like boarding an airplane. If we have sent you an invitation, you then have a seat to get an injection. So it's important for people to not share that, and we're going to be doing some work around this to try to make sure that if you've got your invitation from us, don't copy that and say, hey, they're vaccinating, because that then allows people to start jumping in the line and skipping in front, and it starts to then you risk losing your seat. If the person you send it to sends it to 5 other people, and those 5 people get there ahead of you, then we've got a problem. So it's important not to share that with anyone. And it's also important, I've been asked to mention to folks that one of the things that is to keep an eye out for scams. You are going to see, you've seen the VAC site that the state put up, and that's a legitimate site, but you may see other sites pop up and say, get your vaccine scheduled here, and they will ask you for your information. Beware of that. Montgomery County will send you an HHS notice, a notice through this system, the pre-registration piece that says come and schedule your appointment. If you didn't get it from HHS, then don't regard it as valid. And if you share it with someone and they register using your registration, it's unlikely that we're going to honor that registration. They're scheduling an appointment. So, but you'll get a notice. I just posted in the chat that the team is telling me that the confirmation for registration is being caught up. We have 70,000 people in the system, and we were able to send email confirmations to about 20,000 of those as of yesterday. They're going to take about a week to get caught up on getting the emails out to folks. And the text messaging system is getting an update as well. So they will be coming, so please be patient with them, but give it a week. My team has asked me to share with you not to ask people not to re-register at this point, because it creates duplications that then we have to go through the system and sort out. So, that's my. You'll get a note from us, and it will tell you what to do next.
Fantastic. Dr. Kroll, thank you so much for being able to connect with your team and get us a response before the end of the meeting. That is very, very much appreciated. All right, at this point, I just want to remind everyone that the next time we are going to be all together as a large advisory group is going to be April 21st, same place, same time. We'll send you an invitation in your email system. And the work group co-leaders, and you know who you are, we're going to meet next on March 24th. So again, watch your agenda items. I want to thank everyone who participated. I want to thank again Dr. Kelly. I want to thank Marsha, our wonderful senior fellow for Age-Friendly Initiative, as well as helpers behind the scene who have made sure that we are connected and we can be productive online. Gloria and Tremaine. So Gloria Huggins and Tremaine Jones, thank you so much, everybody. So stay well, stay safe, continue to do the right thing with the mask and the 6 feet, etc. and we'll be in touch. And this group is absolutely awesome. This is an infrastructure for us to communicate, get things done together. And so I am so excited that we can continue to do this during this challenging time. Be well, be safe. Thanks, everybody. Until next time around.
Take care, everyone. Stay safe, please.
Take care.